This is Blood and Cancer News. I'm your host, Nick Andrews. Coming up in the news this week, atezolizumab's FDA approval for triple-negative breast cancer is in jeopardy. Pralsetinib is the second drug in the U.S. approved for RET-positive non-small cell lung cancer, and unexpected results in COVID-19 cytokine storm data. Remember, in every episode of Blood and Cancer News, you can find links to the news stories in the show notes, as well as links to the original sources. You can email Blood and Cancer at podcasts@mdedge.com. And now this week in Hematology Oncology News. Our top story today, all breast cancer patients who develop a second primary cancer should undergo multi-gene panel testing. This is according to a paper published in JCO Precision Oncology, and of course you can find a link to that paper in the notes. In the paper, the authors pointed out that women with breast cancer have between a 4% and a 16% lifetime risk of a second primary cancer. However, it's not clear if mutations in genes aside from BRCA1 and 2 are enriched in patients with multiple primary cancers. In this study, researchers identified pathogenic germline mutations in 17 cancer susceptibility genes in patients with BRCA1/2 negative breast cancer in two separate cohorts. In cohort 1, there were 1,000 high-risk cancer patients. A little over half of them had multiple primary cancers, and the rest had a single breast cancer. Cohort 2 included over 1,800 familial breast cancer patients, 340 with multiple primaries, and more than 1,400 with a single breast cancer. The researchers assessed mutations in these cohorts and compared them with mutations in a control dataset. The researchers reported that pathogenic mutation rates were higher in both cohorts for patients with multiple primary cancers compared with patients who had single primaries. In cohort number 1, the overall panel positive rate was about 8.5% for the multiple primary group and 4.9% in the single primary group. In cohort number 2, the overall panel positive rate was a little over 7% in the multiple primary group and 4.2% in the single primary group. In both cohorts, younger age at first breast cancer was associated with higher mutation rates. However, the age and onset of cancers other than breast cancer was not related to the mutation rate. Dr. Catherine Nathanson, the senior author of this study, is a professor of BRCA-related research at the University of Pennsylvania in Philadelphia. She said that regardless of age, mutations in genes other than BRCA1 and 2 were found in at least 5% of patients with breast cancer and another primary cancer. And mutations other than BRCA1 and 2 were found in up to 25% of patients with their first breast cancer at 30 years old. The researchers also identified genes associated with multiple primary cancers. TP53 and MSH6 mutations were significantly enriched in patients with multiple primaries, but not single primaries. ATM and PALB2 mutations were significantly enriched in both groups when compared with controls. The researchers noted that high penetrance cancer genes were responsible for higher mutation rates in the cohort enriched for early onset breast cancer and non-breast cancer second primaries. Moderate penetrance cancer genes were responsible for the higher mutation rates in the cohort enriched for familial breast cancer and second breast cancer primaries. So what does all of this mean for breast cancer screening and for prevention? Well, according to Dr. Nathanson, the results could lead to better implementation of cancer prevention and screening. The results suggest that age should not be part of the criteria for genetic testing in patients who have more than one primary cancer. Indeed, these patients are at high risk and should be recommended for testing regardless of their age. Future research will look at potentially missing mutations. Dr. Nathanson said that with targeted sequencing, structurally rearranged genes might be missed for those at high risk. We move now to an FDA alert about atezolizumab for patients with previously untreated, inoperable, locally advanced, or metastatic triple-negative breast cancer. A statement from the FDA said that according to the data from a Phase 3 IMpassion trial, atezolizumab plus paclitaxel is ineffective in this patient population. The data showed that atezolizumab plus paclitaxel did not significantly reduce the risk of cancer progression and death compared with paclitaxel plus placebo in PD-L1 positive patients. Additionally, interim overall survival results favored paclitaxel plus placebo over paclitaxel plus atezolizumab in both the PD-L1 positive population and the total population. And as a result of this, healthcare professionals should not replace protein-bound paclitaxel with non-protein-bound paclitaxel. Atezolizumab is approved for use in combination with protein-bound paclitaxel, also known as nab-paclitaxel, to treat patients with unresectable, locally advanced, or metastatic triple-negative breast cancer whose tumors express PD-L1. The combination was granted accelerated approval for this indication last year. Dr. Melinda Telly is an associate professor of medicine and director of the Stanford Cancer Institute Breast Cancer Program. According to Dr. Telly, the FDA can move to revoke the approval of atezolizumab for triple-negative breast cancer because it was an accelerated approval. Dr. Telly explained that atezolizumab was granted accelerated approval based on the results of Impassion 130. In that trial, researchers compared nab-paclitaxel plus atezolizumab with nab-paclitaxel plus placebo. She said researchers hoped that additional data from Impassion 131 would be used to support the conversion of the accelerated approval for a full approval. Since Impassion 131 was negative, it unfortunately places the status of atezolizumab in jeopardy in triple-negative breast cancer, as the benefits were not corroborated in Impassion 131. The FDA stated in its alert that it will review the findings of Impassion 131 and will communicate new information regarding Impassion 131 results and any potential changes to prescribing information. Dr. Telly noted that we need to wait for full presentation and publication of the study results, though. She said that in her assessment, the negative results from Impassion 131 are most likely due to differences in patient selection from Impassion 130. The full results of Impassion 131 are scheduled to be presented at the 2020 ESMO Virtual Conference, which begins September 19th of this year. And a second drug is now available in the U.S. for use in the treatment of patients with metastatic non-small cell lung cancer who test positive for RET fusions. The new drug is called pralsetinib. The FDA granted it accelerated approval for its indication on the basis of response rate data, and continued approval for this indication depends on clinical benefit in a confirmatory trial. Pralsetinib joins selpercatinib, which was approved in the U.S. in May 2020 as the first RET-targeted therapy. Selpercatinib is also indicated for use in RET-positive non-small cell lung cancer and was approved for use in RET-positive medullary thyroid cancer and RET-positive thyroid cancer. Pralsetinib is still awaiting approval for these thyroid cancer indications. Both drugs are taken orally. Pralsetinib can be taken once daily. Selpercatinib is taken twice daily. For both drugs, before treatment is initiated, laboratory testing is needed to show that a RET gene alteration is present in the tumor. RET fusions are found in approximately 1-2% of patients with non-small cell lung cancer. They are one of a number of tumor-specific gene alterations found in non-small cell that are targeted with an approved drug. The approval of pralsetinib comes from the results of a phase 1/2 trial known as ARROW. You can find that trial in the show notes. In the ARROW trial, researchers evaluated 87 patients who had previously been treated with platinum-based chemo. In these patients, the overall response rate was 57%, and the complete response rate was 5.7%. The median duration of response was not estimable. The trial also included 27 patients who were treatment naive and were ineligible for platinum-based chemo. In this group, the overall response rate was 70%, the complete response rate was 11%, and the median duration of response was 9 months. And finally today, unexpected results in a new study of COVID-19 and cytokine storm. In a letter published in JAMA, researchers reported that cytokine storm does not play a major role in more severe COVID-19 outcomes. Dr. Peter Pickers is an MD PhD affiliated with the Department of Intensive Care Medicine at Radboud University Medical Center in the Netherlands. He and his colleagues compared cytokine levels in critically ill COVID-19 patients with cytokine levels in patients with bacterial sepsis, trauma, and those after a cardiac arrest. Dr. Pickers said that he and his colleagues were surprised by the results. He said that for the first time, the team measured the cytokines in different diseases using the same methods. The results showed that the circulating cytokine concentrations are not higher in COVID-19, but in fact, they are lower compared with other diseases. Normally, cytokines trigger inflammation and promote healing after trauma, infection, or other conditions. Although cytokine storm remains ill-defined, the authors noted that many researchers have implicated a hyperinflammatory response involving these small proteins in the pathophysiology of COVID-19. However, the question remains whether all cytokine storms strike people with different conditions in the same way. In this study, The researchers examined 46 patients with COVID-19 and acute respiratory distress syndrome, of course ARDS, who were admitted to the ICU at Radboud University Medical Center. All of the patients underwent mechanical ventilation and were treated between March 11th and April 27 of 2020. The investigators measured plasma levels of cytokines including tumor necrosis factor, TNF factor, interleukin-6, and interleukin-8. They compared the results in this group with those in 51 patients who experienced septic shock and ARDS, 15 patients who experienced septic shock without ARDS, 30 people with out-of-hospital cardiac arrest, and 62 who experienced multiple traumas. The team used historical data for the non-COVID-19 cohorts. Compared to patients with septic shock and ARDS, the COVID-19 cohort had lower levels of TNF, IL-6, and IL-8. The differences were statistically significant for TNF as well for IL-6 and IL-8 concentrations. In addition, the COVID-19 group had significantly lower IL-6 and IL-8 concentrations compared with patients who had septic shock without ARDS. The researchers likewise found lower concentrations of interleukin-8 in patients with COVID-19 compared with out-of-hospital cardiac arrests. Interleukin-8 levels did not differ between COVID-19 and trauma groups. Furthermore, the researchers found no difference in interleukin-6 concentrations between patients with COVID-19 and those who experienced out-of-hospital cardiac arrests or trauma. However, levels of TNF in people with COVID-19 were higher than in trauma patients. The small sample sizes and single-center design are limitations of this study. And that concludes this edition of Blood and Cancer News. Blood and Cancer is produced by MD Edge editor Jennifer Smith. All of our podcasts are produced by MD Edge executive editor Kathy Skarbek and the senior VP of Medscape editorial, Dr. Ivan Aransky. This is Blood and Cancer. I'm Nick Andrews.